Hi, everybody, and good morning for those of you who are just tuning into this conference. We have an exciting presentation coming up for you now. I would like to introduce to you Dr. Paul Daeninck, medical oncologist and palliative care medicine consultant at CancerCare Manitoba, at the University of Manitoba and the WRHA Palliative Care Program, as well as Dr. Lynda Balneaves, Associate Professor at the University of Manitoba. They will be presenting on pain management for people living with cancer, pills, plants, and other possibilities. And I just want to interject here quickly before folks start putting in comments and questions into the Q&A. Please refrain. Please do not ask for specific clinical or personal recommendations from Dr. Daeninck and Dr. Balneaves. They will be presenting general information and cannot comment on anybody's individual circumstances. So just a little bit of a detail there to pay attention to. But I think I see you there, Dr. Daeninck, and we'll pass over the microphone to you.
Okay, thanks very much, Cheryl. Lynda and I are going to split this presentation up. I'm going to take the first bit, and then we'll hand it over to Lynda, and she'll finish it up here. Next slide, please. There we are. As you've seen with all of us, all of the presenters, we do have learning objectives. These are things that we're hoping to transmit to you in our presentation. And we've tried to make it as straightforward as possible. Next slide. I have a few disclosures. I have worked with some of the companies in the oncology and cannabis setting, if you will. And next slide. And as per this slide, I'm not going to be biased by anything because these are all my own slides, my own recommendations. We will be talking a little bit about what's called off-label use. In other words, not necessarily approved by Health Canada, but supported by evidence. Next slide. Next slide. There we are. And then again, all of the speakers are committed to equity or creating slides that take that into account. Next slide. So pain, if we're talking about pain in cancer, it's a problem that many, many patients present with. And sometimes that pain is the presentation of illness. In other words, I have pain, what's going on? And through imaging, etc., we find that there is a cancer of some sort. It is a symptom that many patients and families say that they fear the most when we've done studies and talking to patients who have gone through cancer treatments. Now, although we have very effective treatments, and we're going to talk about that today, pain continues to be very poorly assessed as well as poorly assessed and poorly treated because of lack of experience. And you can see here that there are still some barriers to good pain management, and some of that comes through things like inexperience for the healthcare providers, myths about pain or pain medication, opioids, and addictions. Next slide. So pain is a very common occurrence. As I said, the prevalence, looking at these studies, is greater than 90%. So you see that many of these patients are coming in and they're complaining about pain, whether it be through treatment, with surgery, chemotherapy, radiotherapy, beyond. Next slide. And although we have good medications, we do know that there are issues or things that patients bring up about that. Often the treatment of pain is a relief to many patients and families because that is an indication that there is some way of controlling these issues. Next slide. I think it's really instructive to know what types of pain there are out there and how do you describe them. So certainly acute pain, pain that happens with an incident or surgery due to the cancer, it usually is qualified or characterized as being present for 3 months or less. Chronic pain, 3 months or more. Nociceptive, which is the word that we use in medicine, we usually mean this to mean some body activity or body part, so bones, muscles, etc. We also use the term bony pain, specifically involving the bones. Neuropathic, it means that we're involving, that the tumor is involving the nerves in some fashion. Nerve pain is a very good describer of this. And then we also will use the term visceral pain, which involves the organs, especially things like the colon, stomach, liver, lungs, etc. Next slide. We initially thought that cancer pain was just from the tumor that was sitting on the nerve or invading into the tissue, causing some sort of problem. Now, after a lot of research over the last 20 to 30 years, we find that there's much more complexity to it. So there's neurobiological, there's molecular mechanisms that are coming from the tumor itself. There's the involvement of pain receptors from the individual's own body. Inflammation, in other words, the immune system activity trying to treat or trying to fight against the cancer, and then both biochemical and mechanical factors. Next slide. So these are some of the words that one can use to describe their pain, and that helps a person like myself know what we're talking about. So is the pain localized? Is it sharp? Is it aching or throbbing? That describes more of a somatic type pain to me. Vague, migrating, radiating, crampy, that could be more of a visceral type pain, and I would look for that. Burning, tingling, shooting, stabbing, lancinating, or electric shock-like is often what we talk about when we're describing nerve-type pain. The electric shock-like is almost a characteristic, a diagnostic characteristic. We certainly know that pain can radiate along different nerve pathways, especially when they've been affected. And you do get some changes in sensation, such as a light touch can be perceived by the patient as very painful. And that to me tells me a lot of information. The other thing we have, of course, is total pain. So it's not just the physical pain that's there, but it's the other sort of inputs, the emotions, the exposure that the patient has had before. If they have had personal trauma, that can bring up a lot of different feelings around pain. Their sense of trust with healthcare professionals, and of course, their own personality. Are these patients copers? Do they have difficulty coping? Have they had other sort of issues that may prevent them from coping well with this? Often we talk about pain or total pain as being suffering. And although there's a bit of a humor here, this is not an unusual situation where patients are telling people about their pain, but they're not getting the right sort of treatment. Next. Now, assessment is really important. For us to know what to treat, we need to ask the right questions. So I want to hear from the patient or the family what their experience has been. That way I can bring in my experience or my knowledge of the pain and help to really focus in and get that pain under control. And you can see these are some of the areas that we want to talk about, things like timing and duration of the pain, where it is, what makes it worse, what makes it better. What's the previous history of pain? Patients who have chronic pain issues often have a more challenging pain to treat. When does it come on? Is it always in the morning? Is it always at night? Does it keep you up at night? And then we want to know severity and quality. So quality, those descriptors that we just went over, severity 0 to 10, 10 being the worst pain. Next. Now, once we have a history, we then can focus our efforts looking at things such as the physical exam. You're talking about pain in your arm. That's where I'm going to be looking. I don't need to examine your foot. It's very important to have that exam to have a better and clearer idea of what's going on. Imaging can help us to focus in and to find out if it's a tumor that's causing the pain, or alternatively, maybe it's not tumor, maybe there's an involvement of the nerve in some form or fashion. I want to find out about blood testing. I like to know about what's going on with the liver and the kidneys, because that will determine what sort of medications I use. Some medications are cleared through the kidneys, so if we don't have very good kidney function, I need to look at an alternative. And of course, sometimes patients will have infections that if we treat those, the pain will get better. Tools like the compass are very important. They give us a better idea of how patients rate their pain. And you can see up at the top there, no pain versus worst possible pain. And then the compass also includes other symptoms that patients may be experiencing through their cancer journey, and it gives me a better idea of how to treat it. Next slide. We now are also using something called NUNA at CancerCare Manitoba. It allows patients to actually contact us and give us more information about these individual symptoms, pain being one of the key ones that we have. Next. One of the big issues that patients bring up all the time is this whole idea about, well, if I get treated with some pain medication, such as an opioid, some people call it narcotics, that will cause me to be addicted. And there's been a lot of press, a lot of media press about patients who have had difficulties with this. This is a myth, to be quite honest. We know that addiction is in the public setting. We know that it's about 10 to 15% of patients have some form of addictive personalities, but it's a very complex thing. And putting you on a pain medication doesn't automatically mean that you're going to be addicted, not at all. And I think this comes from the confusion between what we know as addiction versus a dependence, where your body requires that pain medication because of the presence of pain. Next slide. So dependence, a physical dependence, really is changes in the cell, the way that it works in the presence of opioids. I often say dependence is when your body becomes lazy. It doesn't produce its own pain medication. It depends on the pain medication that we're giving. Tolerance of the pain medication means that if I start at 5 milligrams of one medication, over time that may not work as well, and that may be because your body just becomes too used to it, too tolerant, and then we might have to change it. It's not a sign of addiction, it's just a sign of the tolerance. Addiction is defined more as psychological and behavioral changes. Some of the things that we see, people can't control their drug use. They have compulsive use and the continued use despite harm. And one of the things that we look for in this is what's craving. You have one dose and you're looking for the next dose. You're craving the next dose. Often that's the word that patients use. Pseudo-addiction is something that we see. It's a little bit more complex. It's patients whose pain has not been controlled and they're observed to having to use more and more medications. It's really just an effort to find that control, and we often can do that in our pain and symptom clinics. Next slide. So the spectrum, what can we do to treat pain, is quite wide. And you can see here that there's quite a lot of physical, psychosocial, pharmacologic, and surgical things that we can look at. I'm going to talk a little more about physical and pharmacologic, but I will mention these others. Next slide. So if we're talking about physical modalities, we often are looking upon what is your function. If you're able to engage in normal activities, then walking, cycling, low impact activities would be perfectly fine. We often will look at physiotherapy if we're trying to rehabilitate people after their treatment of cancer, and that might include passive or active stretching. Next slide. If one of the things that we know, swimming is a perfect sport. There's less impact, but yet you're using a lot of muscles, like your total body muscles. Conditioning exercises, mild weight training with the help of a conditioning specialist or a physiotherapist is pretty good. And of course, massage always feels good, no question about that. I put a question mark after Pilates because we're not sure. I mean, sometimes you have high impact Pilates and sometimes you just have something that's a bit more muscle stretching and strengthening. That's certainly acceptable. Next. When you have a person who has low activity level, let's say that they tire easily, then you definitely can look at involving physiotherapy. You can involve passive stretching or passive movement of the limbs. Transcutaneous electronerve stimulation can be very helpful, getting the muscles to feel that they're more active. This is where something like yoga, which is very it helps to stretch the muscles, but it doesn't ask for large impact. And then things like acupuncture, and I think Lynda may talk about this a little bit more as we continue on. One of the things that we do have now at CancerCare Manitoba, Dr. Lindsay Woodrow works through a program called Cancer Rehabilitation. She's a specialist in physical medicine and rehabilitation, and she runs a clinic right beside us on Fridays. So certainly if we feel that rehabilitation is something that's important, we'll be able to engage her in the process. As I said, there are psychosocial modalities. You've talked to, or you've heard from some of the psychosocial specialists in the last couple of days. Things like counseling, cognitive or behavioral therapy, hypnosis have all been shown to be effective in reducing pain problems. Sometimes things like psychotherapy or dignity therapy will help with the emotional background that may be driving some of the pain that people have. Next slide. So, medications. What sort of things can we use to help out with pain? Next slide. We are quite fortunate in Canada that we have a number of different medications. The best way to start is with what we would term non-opioid analgesics. So acetaminophen, anti-inflammatory medications or non-steroidal anti-medications, you may hear from us, ibuprofen or naproxen. Acetaminophen, the Tylenol, is often the trade name that people use. So we often talk about 2 of the extra strength tablets 3 times daily would be a good baseline. They do come as longer acting preparations, so you can get something that'll last anywhere from 8 to 12 hours if pill burden is an issue. And in terms of the anti-inflammatory medications, they're really helpful in terms of inflammatory cancer pain sources. So a patient who may have an inflammation that responds very nicely, this may be the only medication they need. They may not need anything stronger. Next slide. And then in Canada, we have access to all of these different opioids. Again, some people use narcotics. That's more of a pejorative term. Opioids are the clinical term that we would use for these medications. And they may be as light or as least potent as codeine, or as strong as something like methadone or fentanyl. And these drugs do require some specialists to be involved in their treatment, in their prescribing. Often family physicians do have some training in the use of things like codeine, morphine, oxycodone. But when it comes to drugs such as hydromorphone, methadone, and fentanyl, this is where you really want to bring in your pain specialists, both from CancerCare Manitoba or from the chronic pain clinic here in Winnipeg. Next. These drugs do come with adverse effects. Often we recognize these and we want to tell people about them even before we start off. So constipation is something that we always address. We often will give laxatives to anyone who's starting opioid analgesics. Nausea, vomiting, again, these are things that we do watch for. Only about 1/3 of patients will have any problems with that. And often if the patient is on chemotherapy, they've already got an anti-nausea medication at home that we can use. Some of the other adverse effects are things that may be what we call you develop tolerance to. So that dry mouth may go away after a period of time, that drowsiness as well. Confusion or memory, that often is a sign that the drug is not being cleared properly, so we have to look at a different option in that point. The sort of options that we have when people present with these adverse effects, we look at different medication doses, we look at different opioids, we look at different routes of administration. So oral may not always be the best. Sometimes we can look at topical, such as a pain patch, or even a rectal suppository. Next. In addition to pain medications like opioids, there are others that we call targeted medications, targeted therapies. And these are medications that help to treat pain, but they aren't necessarily pain killers. So a drug like nortriptyline was actually developed as an antidepressant, but we find that it works very well for some forms of neuropathic pain. Anti-epileptic drugs, pregabalin or gabapentin, some people will know, have been used quite widely. And then there are other medications such as this NMDA receptor agonist, so that's N-methyl D-aspartate receptor agents, drugs like ketamine or methadone. Some people may know methadone as an opioid addiction drug, but we actually use it widely for pain medication as it is very strong and has lots of good activity in nerve-type pain. Other drugs, such as the bisphosphonates, which are helped to strengthen the bone, have been found to help reduce bony-type pain in many patients. Next. There are other things that we can use. Certainly radiation has been shown to help with bony type pain. In about 80% of the patients, we find that the reduction in pain is quite remarkable and usually happens fairly quickly over 2 to 3 weeks and may continue on as many as 8 to 12 weeks, depending upon the location of the tumor. Next. Monitoring is really important. If I give you a pain medication, I want to know the outcome. I want to know if it benefited you. I want to know if you're having difficulty with it. And we want to know, and we want to engage patients and families in this activity as well. Next. I will often start the patient on some form of pain medication, but then I will have a member of my staff or myself will talk to the patient fairly quickly within a few days to find out if we're actually where we want to be. Even if we're only partway there, that gives me good information about moving forward. Certainly, we ask the family, again, to be helpful in all of this. And then we, again, Mununa is something new that we're just getting our heads around, but I think it's going to be really useful for us because we'll be able to respond in a timely manner. The other thing you need to know is that there's always a doctor, a medical oncologist on call 24/7. If it's myself or my colleagues who work in the pain and symptom management group, you would get specific information about pain management, but you're never alone. There's always someone out there to help. Next. Now, one of the things that we were also asked to comment on was the use of cannabis for patients. And certainly I feel very comfortable talking about this. This is something that many people find controversial, despite having, the Health Canada legalize the use or the the use and the ownership of cannabis. Next slide. For those of you who have never seen a cannabis plant, this is one of those, and you can see that there are these little nubbins on the plant itself. Next. And these are where the cannabinoids are located. The tips of those have a concentration of a lot of cannabinoids, so these are chemicals within the plant that can help us to treat some of the pains that we see. Next slide. This glossary just helps us to understand what we're going to be talking about. Some people will still refer to this plant as marijuana or marijuana. That's again a legal pejorative. Cannabis is the scientific name. We want to keep it clinically relevant. Indica or sativa, different cultivars of cannabis that are available. However, what's more important is the presence of what we call THC, tetrahydrocannabinol, or CBD, cannabidiol. Those are the cannabinoids that are active and will help us to determine what sort of treatment you require. You'll often hear me during the next couple of minutes talk about cannabinoid-based medicine. This is a term to describe therapeutic use of cannabis for patients. Next slide. Now, this is just a simple flow chart to give you an idea of what we're looking at. So in a cannabis plant, we have lots of different compounds. There are more than 100 types of cannabinoids. Out of those, though, again, the tetrahydrocannabinol, cannabidiol are the ones that are the most active. And you see that THC can cause some psychoactivity, so some euphoria, hallucinations. People who are using it for recreational purposes often are looking for high doses of that. Cannabidiol, CBD, has become a darling of patients looking for quality of life, and especially has been seen a lot in the media. Next slide. In addition to the cannabinoids in the cannabis plant, there are these things called terpenes. These are aromatic substances that give it a characteristic smell or taste. And you can see that some of these have medical indications all on their own, such as limonene, alpha-pinene, myrcene. All of these seem to have had some activity, especially when they've been used in isolation, but when they're combined with cannabinoids may have even more activity. Next slide. So one question that comes up often is, why do we use this? Why are we using what used to be considered an illegal drug? Well, it's partly because we have an inherent cannabinoid system. This is a system of receptors, of transmittable substances, what are called ligands, within the body, and it helps to control or moderate many systems within the body. And you can see by the cartoon that you can find a lot of these in various regions throughout the body. Next slide. Who uses it? I'm not going to go through this in much detail, but you can see that the use of cannabis has increased over the years. 2000 was when it was deemed medically available, and it was 2017, 2018 that it was made recreationally available. And now the most recent information estimates that about 14-15% of Canadians are using it for some form, for a medical purpose. That works out to somewhere between 5 and 6 million people in Canada at the moment. Next slide. In terms of what are people using it for, all we have to do is look at the literature. This is a questionnaire that went out to patients who were attending a palliative care clinic. These were all cancer patients. And you can see, next slide, that most patients are using it for pain, but there are other reasons that they may use it. We'll focus more on pain today. Next slide. There is evidence on this. This isn't something that we're just coming out of the blue and saying, hey, this is something that we could use. Rather, these are actual evidence. We have different sort of reviews that are done by specialists, experts in the field, and they come up with the recommendations for us as clinicians. Next slide. In terms of cancer, again, the best evidence comes out in nausea and vomiting associated with chemotherapy, cancer-associated pain. There is some evidence in helping with appetite or sleep, a little bit of evidence helping out with anxiety. That's a growing area. And cancer treatment, there really isn't very much clinical evidence, although there's a lot of research that continues on. Next. So the question comes, how much do we use? What kind of dosing do we use? This is a recent study that was published just a couple of years ago in a palliative care population. Again, most of these patients had cancer. And you can see that they were allowed to use both CBD or THC, and they chose their dose. They chose the dose that worked best for them. And with that, more than 40% found that they had some improvement in their symptoms, especially things like pain or nausea. And another 40+% said that they had better quality of life using these types of medications. Next slide. So I think that it's important for us to kind of review how do we use cannabis safely. And, unfortunately, 2 tokes call me in the morning doesn't quite cut it. Next slide. There are what we call prescription cannabinoids. These are synthetic medications that are available. Nabilone is the synthetic that's available for has been around for a number of years. Nabiximols, also known as Sativex, has been around for at least 10 years. It too is made up of both THC and CBD, whereas Nabilone is a pure THC analog. You may have heard about other things like cannabidiol or dronabinol. Unfortunately, these are not available in Canada at the moment, not as a prescription. Next slide. However, within the Health Canada framework, we can order medical cannabis products. And how do we do that? Well, certainly a discussion with the healthcare professional is really important. Once the patient or family have chosen a producer, in other words, a company that provides medical cannabis to you, you would sign up or register with the company. Once that registration is done, then a doctor or healthcare professional can put in a medical document, which kind of as akin to a prescription, although not exactly the way that Health Canada has defined it. And then the company matches those two, sends the product out to the patient once they've ordered, and then they're able to use to their heart's content. Next slide. Products that are available from these licensed producers have grown over the years. Now you can actually get extracts in oil, gel caps or capsules. You do not have to smoke, although you could if you're interested in inhaling or vaporizing. That's available as well. Now we also have what's known as edibles, so things like gummies or chocolates. The number of the companies are making vaporizer cartridges. These are not like vapes that you get over the internet. These are pure cannabinoids within the cartridge that you can use in a medical vaporizer. Next slide. In terms of what to choose, and unfortunately it doesn't look like this has come out very well, but what to choose is really important. If you have more chronic pain, something that lasts longer, like an oral product or an oral mucosa would be better than having to smoke or vaporize every 4 to 6 hours. If you're having sudden onsets of pain and you need something quickly with quick onset, short but potent activity, that's where something like a vaporizer might be helpful. Next. It's hard to know exactly how we dose cannabis, and often what we need to do is work with the individuals to figure out exactly what we're looking for. So a patient who has used cannabis before may have a different dosing than a person who's never seen it previously. If we're looking at a product that contains just CBD or just THC or a little bit of both, that would be really important. And also the route of use. Again, oral is going to take longer to kick in, if you will, to actually be active, but it will act for anywhere from 8 to 12 hours. Next slide. We, as in the clinical world, talk about start low and go slow. Patients who have never seen cannabis before should have a starting dose that's very low to prevent any problems with side effects. And we often will time it so that we're taking advantage of things like if the patient is saying, I can't sleep well because of my pain, well, let's dose it at night. That way you'll have a better sleep because you may take advantage of some of the drowsiness that people may find when they start cannabis. Next. In terms of CBD, a little different, a little more challenging because we don't see the same sort of guidelines that we have with THC. CBD is relatively new to us as a dedicated medication. So what we're finding is that we're starting at higher doses. I tend to use anywhere from 10 to 20 milligrams per dose for patients who've never seen it before. I'm looking for a target dose of somewhere around 50 to 100 milligrams daily, which is quite a bit different than THC, and that distinction needs to be made when we're talking to patients about it. Next. There's always a question about who should or shouldn't use cannabis. Because of the effects of THC, we have to be careful about giving it to patients who may have psychosis or schizophrenia. THC can also affect the blood vessels, so therefore people who have difficulties with angina or heart disease, a good discussion about how to use it or maybe not to use THC, just CBD. People who are on oxygen shouldn't be smoking, so we would, put that out there as a problem. Maybe they want to be using oral or some other sort of route of administration. Pregnancy or breastfeeding, of course, that kind of goes without saying. It can affect the baby and the baby's development. People have an allergy to cannabis, and that could be a problem. The federal government says that, if you're 19 or younger, you shouldn't be using cannabis. Yes, but yet we know that some patients who have very specific conditions can benefit from it. So I say it's a relative contraindication, something that needs to be discussed with the physician. These are the side effects that have been seen in clinical trials using cannabis for medical purposes. Most of these come on quickly and are kind of fade off as people become tolerant of it. Sometimes it's more due to the high use or the high dose of THC. So therefore, things like dizziness or disorientation may happen with the first dose or two, and then it settles down and you don't see it anymore. Next slide. And finally, we always warn patients about using cannabis and driving. This is really important to move forward. I think that we need to know that if you're using THC, you should not be driving within anywhere from between 4 and 8 hours after you're taking it, and that includes both smoking and oral pills. We don't see the same issues, the same intoxication with people who are using CBD products. Next slide. Now, this is a bit of self-promotion. If anyone's really interested in more information around this area, this was a book that we've recently published looking at both cannabis, cannabinoid-based medicines in cancer care. This is accessible through actually Amazon, of all places, as well as Springer itself. And I'm going to turn it over to Lynda now.
Good morning, everyone. So I'm going to be touching more on complementary therapies. Sorry, I'm just trying to get everything going here. Yeah, and in terms of my disclosures, I have received some research grants from various funding agencies, both locally as well as at a national level, as well as I've been part of the Society for Integrative Oncology's development of guidelines, and we did receive funding from the Samueli Foundation, which is in the US. And other than that, I am the Deputy Director of the Canadian Consortium for the Investigation of Cannabinoids and have received a small stipend related to that. And in terms of any potential bias, this has been mitigated by having evidence-based information shared in this presentation. I'm only using generic names, and there's been no commercial input to these slides. And I am committed to supporting and advancing equity. All right, so for my presentation, which I'm going to go a little bit quickly because we want to make sure we have lots of time for questions, I'm going to be really focusing on complementary therapies, on pain, as well as symptom management. I won't be focusing on treatment because we actually don't have some great trials out there that really support any of our complementary therapies around treating cancer itself. I'm also going to end by just touching on some of the things that I would encourage you and your families to think about when you're making informed decisions about using complementary therapies. So I'm going to jump right into talking about complementary therapies and the management of pain, which really follows up well from what Paul just described. And I'm really pleased to announce that the Society for Integrative Oncology partnered with ASCO, the American Society for Clinical Oncology, very recently. And at the end of September, we actually published international guidelines on the role of complementary therapies in the management of oncology-related pain. And I do want to do a shout out to Dr. Jun Mao, who is the chair and director of integrative medicine at Memorial Sloan Kettering in New York City. He was very gracious in sharing his slides related to this for today's presentation. So to jump in, and as Paul mentioned, I was going to mention acupuncture. There are several types of pain that we can actually recommend acupuncture as being used. And one of the first ones is related to individuals living with breast cancer that are experiencing aromatase inhibitor related joint pain, which we know many individuals do experience from this treatment. This recommendation is based on 4 systematic reviews as well as 5 clinical trials. And the evidence is actually quite strong at the moderate level that suggests that when people receive acupuncture, it actually reduces moderate and severe pain experienced related to aromatase inhibitors. And this was actually compared to a sham acupuncture as well as a control group. And we did see the significant reduction in pain. We also can recommend acupuncture for very general or musculoskeletal pain that you may be experiencing related to your cancer, as well as secondary, perhaps, to some of the conventional treatments that you're receiving. And in this case, it was based on 8 clinical trials that were conducted. There was actually a very large trial with 360 patients that looked at electroacupuncture, and that's where they add electrical currents to acupuncture needles that are inserted at acupoints. They also had another arm of this study that had auricular acupuncture, which is acupuncture that's done in the ear, and then they compared that to usual care. And they actually showed that electro acupuncture reduced pain by almost 2 points on a 1 to 10 scale, which is quite clinically significant, and that auricular acupuncture in the ear reduced pain by 1.6. So both of these seem to be valid ways of experiencing relief from generalized pain. And the nice thing about acupuncture is that there's not a lot of toxicities attached to it. Some people in the ear acupuncture did withdraw because they were experiencing pain. Sometimes there's a little bit of bruising and bleeding. And you obviously, as I'm going to talk about later, want to work with someone that's experienced in working with people living with cancer, that know how to do proper insertion of the needles, as well as know how to use sterile techniques. When we're turning towards pain that people may be experiencing with advanced cancer, particularly if they're moving into a palliative or hospice care setting, there has been a sufficient trial work done to suggest that massage can be helpful. And I know that Paul mentioned this already. There was an actually very large multi-center trial that was done in the US, as well as a systematic review that was done that suggested that people that received a massage that included gliding strokes, some squeezing, rolling, trigger point release, as well as kneading of the muscles, that these people actually experienced immediate relief from their pain. They also were able to sustain these outcomes for up to 2 weeks. And typically, if you're receiving massage, you're receiving it on a 2 to 3 week basis. And obviously, there was no side effects associated with massage, and it seemed to help people not only with their pain, but also with their emotional coping with their pain, as well as their prognosis. Another complementary therapy that's come out as having strong evidence is hypnosis. And this has been particularly looked at for individuals that are going through a procedure, some type of diagnostic technique. And there's actually been 5 studies that have been conducted that have actually shown that when people are receiving hypnosis either prior to the actual intervention or the diagnostic procedure and during that procedure, that people are better able to cope with their pain, as well as they report less pain. And the suggestion is that this should be done not only before, but also be carried through throughout the procedure. It also seemed to have an impact, which I'm going to mention a bit, around anxiety and the anxiety that people may experience as they're undergoing these diagnostic procedures. The other thing as well is that it had a positive impact on people using less medication as well. You know, this is a body or a field, I should say, that is still needing a lot more research. We need more rigorous trials. We need larger studies. We need multi-center studies. And that is underway, thankfully. So we only have weak recommendations in terms of the potential role right now of yoga, guided imagery where you're visualizing and doing meditative breath work, as well as music therapy in helping people in coping and reducing their experience of pain. Hopefully, with more research, we'll be able to move these recommendations to a higher level. I want to touch on a few other complementary therapies. I'm not going to go into too deep of a dive, but I'm happy to answer questions around them afterwards. The Society for Integrative Oncology and ASCO were actually given funding to complete 5 clinical guidelines. And we're just finishing up the anxiety and depression guideline, which we hope will be published in early January. For anxiety and depression, the therapies that are really rising to the top in terms of having the most rigorous evidence is around meditation and mindfulness. In cancer, we have a therapy called MSBR, which is mindfulness stress reduction therapy. And I know that we've offered it at different times at CancerCare Manitoba. And people do report it helpful in managing not only symptoms of anxiety, but also depression. Yoga is also coming out with very strong evidence that people that engage in a regular yoga practice, it doesn't need to be one that's tied to the more yogic spiritual practice, but just more of the movement therapy, has been found to be helpful in managing people's emotions. Art and music therapy, the expressive arts, some people do find these very relaxing and can also be a distraction, help them manage, again, anxiety and depression. And, for natural health products, we don't have great trials in cancer around many of our natural health products. There's often concerns about interactions. And while we do have strong evidence that St. John's wort, which is a herbal remedy, is very useful in managing mild to moderate depression, there is concern not only in cancer, but across other health conditions, that St. John's wort significantly impacts the metabolism of medications. For a lot of medications, when you take St. John's wort, they're cleared from the body too soon. So you do need to be careful, particularly if you're undergoing something like chemotherapy or hormone therapy, that you're not clearing that medication too soon. And that's where consulting with a pharmacist is a really great idea to make sure that you're not disadvantaging the therapies that you're undertaking. When it comes to sleep issues, which we know many individuals living with cancer experience, we are creating a guideline around this as well, but it probably will not be finished until next year. When you look through the literature, though, meditation, mindfulness definitely are at the top of the list. We also find some of the movement therapies, not only yoga, but Tai Chi and Qigong, which come from more Asian medicine traditions. People find them useful. And there is evidence that it helps people with getting to sleep as well as retaining, staying in that active sleep state. Some individuals do find massage useful as well, which might be kind of correlated with their management of pain. And then lastly, I know there's a lot of interest in melatonin. This is a kind of hormonal compound that we know is produced and helps the body reach sleep and stay in sleep. But when we see the clinical trials that have been done in people living with cancer that are having sleep issues, we have some studies that suggest it's useful, and then we've had some other studies that have suggested it's not. So it's very mixed results. And again, taking any natural health products, you should consult with your healthcare team just to see if there's any concerns around interactions. And I know for some individuals, if they're taking moderate to large dosages, it can actually be disruptive to sleep and have result in things like headaches, as well as some people experience nightmares. When you turn to something like fatigue, again, we're doing a guideline on this. It's going to take a while for us to see it come out. But the positive evidence right now is around things like music therapy, exercise, which always seems a little bit counterintuitive, but it's been shown over and over again that aerobic exercise, resistance training with weights, movement therapies like Qigong and yoga help people in improving their state of fatigue. And there's beginning evidence around acupuncture and acupressure where you're not inserting needles, but you're pressing on key points in the body. We need more robust studies to give that as a clear recommendation. For nausea and vomiting, acupuncture again rises to the top, as well as progressive muscle relaxation, which is basically a process of contracting and releasing bodies or muscles throughout your body. People find that useful. It's almost a distraction technique that some people find helpful. There's been, again, some clinical trials that suggest that ginger, where you make the actual ginger root and cut it up and put it into hot water and make a tea of it. Some people do find that useful in managing nausea and vomiting that's not being managed by their current medications. But we've had some more recent studies conducted that suggest it's not useful. So this may be something that's very individualized. And there needs to be some care in taking large dosages of ginger, particularly if you're taking it as a supplement, because ginger does affect things like blood sugar levels. It also can have an antiplatelet effect. So if you're going for surgery, if you are using other medications that cause blood thinning, you just need to be a bit cautious. And then just to kind of wrap up around mucositis, which is where you get sores in your mouth, sometimes secondary to chemo or to radiation therapy. The evidence actually coming from MASC, which is the Multinational Association of Supportive Care in Cancer, they've actually come out and suggested that oral glutamine, particularly in people living with head and neck cancers, is useful in terms of preventing as well as managing mucositis. And there's beginning evidence. I'm seeing more and more trials coming out suggesting that actually honey, topically applied in the mouth, can actually be a powerful antibiotic antibacterial agent and can be useful in people experiencing mucositis. One caveat, though, is you have to make sure that you're using a honey that is sterilized. You don't want to be using anything that has any bacteria or fungi in it when you have those open sores in your mouth. So I know we're really short on time, so I'm just going to kind of quickly touch on some key things that I encourage you to reflect on and think about if you're making decisions around the use of complementary therapies. And I always start by saying, check in with your lifestyle first. There's no sense in spending hundreds of dollars on therapists and therapies if at first you're not eating a healthy diet, you're not getting adequate sleep, you're not exercising. And I know all of these are very challenging when you're going through the cancer experience. But, working with someone in terms of, eating a healthy diet, eating whole grains, considering perhaps, how much sugar you're consuming, using lots of fruits and vegetables. We know that the evidence suggests that when people are eating that type of a diet, we see better outcomes when it comes to cancer. Same thing with exercise, same things with managing things like tobacco use and sun exposure. So this is just a good chance for you to check in on your overall health. I think it's also really important when you're thinking about complementary therapies, or if you have a lot of people in your social network recommending them, that you really reflect on what you want to achieve from that therapy. Yes, there are many people that will say, I want to take something that's going to prevent my cancer from coming back. But you may also be wanting to use it to address a side effect that you're experiencing from cancer treatment. It might just be an opportunity for you to do a therapy that you've been always wanting to try, perhaps like beginning a yoga practice, or helping you cope with the impact of your illness. Knowing what your goal is going to be really important when you're looking for evidence and talking to therapists and your healthcare team about why you're using a therapy and why you're interested in it. And I really encourage you to reflect on what your own beliefs are and what your values are and your priorities, and perhaps your own cultural experiences, because that may influence the type of therapies that you're going to be drawn towards, that you can commit to, or are important to you and your family. And I've been talking a lot about evidence, and, I'm a registered nurse. Even though I do a lot of work in the field of complementary therapies, I really encourage you to look for the highest quality evidence. And that's those meta-analyses where we combine studies together, systematic reviews where we've searched the whole literature and we found the top studies, or these randomized controlled trials. You'll see in the media a lot of reports around, coffee causes cancer, coffee kills cancer. And then sometimes when you unpack those articles, they're based on mice. They're based on test tubes with cells. And while that's important evidence, it doesn't necessarily mean the same effects will be seen in the human body. I don't want to discount evidence that comes from your own experience, perhaps from your culture, but I think you need to balance it in terms of having the highest quality evidence around safety and efficacy in the decisions that you make. And if you're interested in finding out what the latest clinical trials are, you can always go to clinicaltrials.gov. It's a US website, but all the international trials are uploaded to that site, and you can see what the latest evidence is, as well as if there's a trial in your area that you can go into. There's other credible information sources that are out there. I'm just going to touch on some. I have a slide coming up that gives you the links to all of these. But the National Cancer Institute has some great monographs on various therapies. The Society for Integrative Oncology, we have links to all of our guidelines from our website. There are some national centers, like the National Center for Complementary and Integrative Health in the US. They have an app you can download on your phone called HerbList app that gives you kind of the 411 on, the evidence and the side effects and the contraindications that you should be aware of around various natural health products. And the same thing is available through Memorial Sloan Kettering. They have the About Herbs and Botanical website, and they also have the About Herbs app that I have on my phone, and I look at it almost weekly. And here's just an example of MSK's website with chaga mushrooms. And they have monographs that are directed towards yourself and your families, but they also have one that you can print off and share with your healthcare team that gives a little bit more details about the evidence. If you're looking at natural health products, I do recommend that you also go to websites like Natural Medicines. It does involve a small cost to join, but they have things like interaction checkers. So if you're on other medications, it gives you a sense of where there may be some cautions and concerns if you're using a certain natural health product with that medication on board. The Office of Dietary Supplements in the US also gives you a sense of what is the maximum dosage around vitamins and minerals. And then lastly, if you are using a natural health product in Canada, it should have been approved through the NNHDP. You can look up monographs for all those therapies. It also ensures that there's been some regulation and oversight around the quality of that natural product. What you get off the internet isn't always pure. It may also have contaminations. So I do recommend you look for supplements that have an NPN number. If you're going to a complementary medicine practitioner, I really encourage you to talk to them about whether they're regulated, whether they have certification, either at the federal or the provincial territorial level. Also about their training. Do they have experience working with individuals with cancer? Do they have specific training? For example, if you're a naturopathic doctor, you can go through ONC-ANAP, which has specialized training and certification in oncology for naturopathic doctors. The massage therapist, there is a Society for Oncology Massage that offers coursework as well. And then lastly, acupuncture. MSK offers a course that's specific to oncology acupuncture. And so having that additional training will make sure that they're able to provide the most safe care possible, and also have more awareness about the treatments that you're undergoing. And then lastly, ask them if they're willing to work with your oncology healthcare team. Will they send a summary of the therapies that they're recommending for you? Will they be open to a dialogue? I think that's always important to have your whole team working together. And if you're interested in any of these resources, you can just type in cameoprogram.org, and we have all those resources linked to our website. And then just kind of wrapping things up here in terms of using, any type of therapy, it's really important that you reflect on all the complementary therapies you're using, not just for cancer. And there are a lot of caveats around using natural health products. A lot of these therapies have blood thinning properties. They can cause toxicity to your liver or kidney. A lot of them impact how drugs are metabolized in your body. So if you're on other medications, you need to have that consult with pharmacy. They also can change blood values, for tests. So if you're going in for blood tests, you may need a bit of a washout period around that. And because they can interact with medications, you may be advised to hold off on using some of these therapies until your cancer treatments have been completed. And obviously, you just need to reflect on other things like, are they upsetting your stomach? Are you having an allergic reaction? Do they impact other health conditions you're living with? And that's why I always advise, if you're starting complementary therapies, don't start a ton of them at one time. You might want to take them, every few days. If you're adding on something like a natural health product, see how your body's reacting. See if you're having any side effects. If you're using everything at once, it might be hard to pinpoint what the issue is. And my slides are not advancing. There we go. And I think I've already kind of touched on this, but consider where you're at. If you're receiving active treatment, because of the concerns around how natural health products can interact with chemotherapy and even radiation, or cause blood thinning if you're going in for surgery, you should have a conversation with your team about, is this the right time? Or do I need a washout period and wait until I'm completed? As people move into survivorship, this might be a time to put together a complementary therapy plan. And if you experience a reoccurrence, it might be an opportunity to re-look at your treatment protocols and whether you want to start adding complementary therapies into the mix. And beyond just physical effects, these therapies can take a lot of energy. They can take a lot of time. They can also impact you financially. And so I encourage you to have that conversation with your family to make sure that your quality of life is not going to suffer through the use of these therapies. And then lastly, and I've thread this throughout, is, ensure that you are discussing your use of complementary therapies with your healthcare team. I know not everyone is supportive of it. Ask to speak to someone that would be able to have that open dialogue for you. It's imperative that they know what you're using. It should be documented in your record so that everyone's on the same page and that you receive the most comprehensive and safe care possible. And this will be a decision and a discussion that you'll probably revisit throughout your cancer journey. So just to quickly wrap up, I know I'm a few minutes over, pulling from Paul's presentation, pain is a very prevalent symptom that many of you may be experiencing, but there are numerous treatment options that exist, from the pharmaceutical to the non-pharmaceutical to the complementary, that could help you with that. And make sure you're working closely with your healthcare team to discuss those options and make sure that you're being monitored in terms of efficacy and safety. And there's growing interest, obviously, not even among people living with cancer, but just in the general population, and about the role of cannabis and cannabinoid, and that there is some suggestion in the research that it could help with managing symptoms experienced by cancer. And Paul didn't mention this, but there is some beginning discussion about, does it have a role in augmenting the treatment of cancer? And make sure that you're consulting with knowledgeable individuals that know about cannabis, have experience working with it, so that they're ensuring that you're receiving the best care possible related to cannabinoid-based medicines. And then finally, around complementary therapies, there is increasing evidence that some of these therapies may help in symptom management in cancer, particularly the mind body movement, acupuncture, and the expressive art therapies. Natural health products, the jury is still out. And just ensure that you're using the most rigorous evidence-based information to make these decisions. You're consulting your healthcare team, and you're reflecting on your own beliefs and values as you're making these decisions. And my own little plug, the Society for Integrative Oncology is celebrating 20 years. We're super excited, and we're bringing it up to Canada. I'm co-chair of the conference in Banff. It'll be September 13th to 16th. You're welcome to join us. We have a very robust patient advocacy group, and just excited to see as many people come out as possible. So thank
Well, again, I just want to thank you both for your lovely presentation today. Lots of hearts being shown for you both. So have a great, wonderful rest of your weekend, Paul and Lynda.
Thanks so much, Cheryl. Bye, everyone.